So, as was mentioned, there are some major changes in the content of this course and the recommendations of experts in terms of the optimal management of the emergency airway. And the first is a longer acting paralytic is safer. And that's a paradigm shift from the previous thinking in emergency medicine. The next thing is no paralytic at all if you predict the patient is going to be a difficult intubation. There's a new, essentially, technique called delayed sequence intubation, where essentially we're going to sedate the patient in order to facilitate maximal ventilation to give us as much breathing room as you can as they get hypoxic in order to secure the airway. Passive oxygenation should now be the standard. Every patient that you're intubating, whether you predict them to be easy or difficult, should have passive oxygenation. And finally, getting our specialty back into the expertise of managing the ventilator, because what I see and what I hear is that we intubate the patient, RT's there, we turn, walk out the door, and the RT just puts in their settings and manage the vents, and the vent's alarming, and all we know what to do is say call RT. So we're going to talk about mastery of the ventilator. So in terms of what we're going to do today, the first thing is an overview approach to the airway. And then we're going to talk about, if we predict it to be easy, basically this new drug, this new concept of a longer acting paralytic and some new devices. We're going to talk about delayed sequence intubation for the hypoxic patient. Then we're going to talk about predicted difficult airways and this thing called sedated intubation. We're going to do some demonstrations of some new products that are out there, particularly supraglottic devices. We're going to have a working lunch. We're going to talk about some additional closed cases from MedAmerica Mutual. It's an opportunity for you to share any scareaway stories that you have for us to discuss. Then we're going to spend the better part of the afternoon doing 5 rotating skill stations. There's an end of course test, and then we're out of here. So now we're going to talk about the big picture, and particularly what I want you to take away this course is a deliberate approach to the airway. And that deliberate approach is reflected in your documentation, that your history and physical actually discusses the features of the patient that you thought would either make them difficult or not difficult, what backup you had in place prior to intubation, so that if something goes wrong, the way your documentation reads show that you were prepared for it. And often we're documenting after the fact, but these are the things I want in your mind as you're preparing to secure somebody's airway. So the information from this course, we unabashedly steal from everywhere. So the Ron Wall's course, Levitan's course that I went to in Baltimore, new articles, Scott Weingard, you name it. This course changes literally from course to course. We update and add new information. And this is the best algorithm that we've come up with. And what I want to emphasize is the extremes. So on one side, you've got evaluate the airway, and the other side, you've got surgical airway. And part of that is that every patient you consider managing the airway, I want a little part of your brain to think about, I might have to do a surgical airway on this patient, to at least kind of cross that threshold and have that in your mind. This could go bad, I might have to do a surgical airway, and knowing that that's the end of the algorithm. The next part of this evaluate the airway is to try to predict, is it going to be difficult or not difficult. There's some things that are obvious that's going to make it difficult. There's some things that are subtle. There's not really good evidence-based techniques in emergency medicine to tease this out, so we rely on anesthesia data, which is the best that's out there. If we predict it's going to be not difficult, then we're going to do rapid sequence intubation. It's what we're all good at. But there's a key thing on there, ×3. The maximum times the laryngoscope goes into the mouth is 3 times. So why do you think that is? Yeah, somebody studied it, and essentially after the 3rd attempt, your chance of ultimate success with orotracheal intubation goes to 0. I mean, it really, at 3, it drops almost to 0. And now that's 3 attempts by an experienced operator. So if you're working at a place with residents, the resident tries once, okay, maybe 3 more tries. But if we're a double cover site, Chris tries twice, I try once, we're done. It's a failed airway. Now we've got to do something different. So if the patient is not predicted to be difficult, but we can't get their SATs up, why is that? Well, they're anoxic, so they're combative. They're pushing the bag valve mask away. They're pushing the BiPAP away. They're tearing the BiPAP off. And so we don't predict they're going to be difficult, but we want to maximize the oxygen before we paralyze them so we have longer time before they become apneic. So these patients, we're actually going to sedate if their SATs are less than 94. We're going to put them on BiPAP or bag them or high flow nasal cannula, try to get their SATs up to 94 or better at 3 minutes, and then paralyze and intubate them 3 minutes later. We'll talk about that in detail. So if we predict they're going to be difficult, we're going this new route. Now, how many of you were trained in residency on sedated intubation? Really?
Not in residency.
Okay. So you in residency, you talk about that, good, because that's relatively new. I would say for the last 3-4 years, there's been no hands that have gone up. And I think the last time somebody raised their hand, they said, well, yeah, some attendings will do it, but some won't. But it wasn't really kind of institutionalized in terms of airway management. So that's a new technique for many of us. Okay, now we're in the failed airway. This is where these rescue devices come in, the LMAs and the King LTD. And if you can maintain the ventilation and oxygenation, you can stay in this spot indefinitely. If you can keep the SATs up, you can call anesthesia, you can get a fiber optic, you can, strategize, whatever it is, as long as you keep the SATs up. But the moment you're in the situation where you're in failed airway and you can't maintain the SATs, immediately the knife comes out and you do a surgical airway. There's something called a crash airway, and a crash airway is a patient that arrives either arrest or peri-arrest, and there's no opportunity to evaluate if they're going to be difficult or not difficult, and we just have to basically manage the airway. Sometimes we need meds, sometimes we don't. Okay, so where do we make errors as emergency physicians? The first place we make errors is that we don't think about the patient, we just paralyze them. We don't consider if they're going to be potentially a difficult airway, and we just take their airway reflexes away. The next thing, and we've all done it, is doing more than 3 attempts at RSI. We've always been successful at it. It always works. Oh, let me just try one more time. Let me just position the head a little differently. Let me try this. So that's one thing we really need to be aware of, especially double covered sites, that 3 is the magic number. And finally, as we talked about in that closed case, the last mistake we make is not recognizing a failed airway and inability to keep the SATs up and not immediately going or at least attempting a surgical airway.